Mbona hii nini haisikiki? Oh. Iko sawa? Hello, good afternoon, Mike. Mic check, mic check. Have you connected on I mean, network is stable? Your network is stable? Okay. Then if log into Zoom,
Welcome everybody. Thank you very much, and apologies for the our lateness. People had gone for lunch, but we apologize. We are running late, so welcome to the pre-symposium, 17th Annual Reproductive Health Symposium of the Nairobi Hospital. We are very grateful to everybody who has supported us. Today it has been a pre-symposium workshop, mainly on ultrasound. We've had a very good session in the morning on scanning, both obstetrics and gynae. And now we'll have a small talk, which is mostly courtesy of GE and their representative. This will be a virtual with Mr. Hilal from Lebanon, but he will be introduced by Dr. Judy Nyaboga, who is a radiologist with very reputable. She being also worked here for a while, I'm sure she'll tell you. Thereafter, we'll have another talk by Judy herself after we close. So we'll have the talk for about 45 minutes, and then questions and answers. And then another talk by Judy on basic radiology, the basics to what to know. So without taking much time, I would like to invite Judy, who will go ahead and invite the speaker for today. Mr. Hilal also will be talking tomorrow on the symposium. We are all invited for tomorrow's symposium. It's free, starting from 8 a.m. in the morning until around, I think, 4:35. So welcome everybody, and thank you very much for those ones who've joined us. So Judy, please take over. Thank you.
Good afternoon, everyone. So my name is Judith Nyaboga. I'm the ultrasound application specialist for GE. You've heard my background. I worked with you team here for 10 years in ultrasound, radiology department. Our speaker today will be Hilal Farah, who is our lead application and sales specialist for women's health, emerging market. Hilal is based in Dubai, but currently he's in Lebanon. So he will take us through the women's health portfolio. These are ultrasound systems that are dedicated for women's health. He will take us through some of the applications that will really help you during your practice. Hilal, welcome. Hilal, you're muted. Hilal. Hi, Hilal. We can hear you. Yes, Hilal, we can hear you.
Now you can hear me?
Yes.
We hear you very well. Please go ahead. Thank you.
Hello, we can hear you. You can go on.
fetal cardiology, fetal therapy, and so forth.
Thank you, Hilal. I think you deserve a big applause. So thank you very much, Hilal. I think that was a good presentation. And I'm sure we've gotten quite some insights on ultrasound. Ultrasound is a new area which now is making it easy both in gyne, obstetrics, IVF. Now, we'll have some questions and answers because we know probably of the connectivity so that we don't lose you. So anybody with a question before which I think Judy will follow with a small presentation as she prepares. Probably I could ask the first question. Dr. Hilal, I can see your Volvuson AVC is quite good. And especially when it comes to what we call antrofollicular count and tracking in IVF or infertility. I don't know, how do you differentiate between mature follicle and maybe a cyst? I know the issue of size will come. But then in terms of your coloring, is there a way you can tell?
Daktari, he can't hear you.
Oh, he can't hear, sorry. Maybe you can ask, maybe you can give the questions and you can ask. If there are questions, maybe you can put to him. You can ask questions and then probably if anybody has.
Try, Daktari. Can you hear
Mr.
us?
Hilal, can you hear?
No, he cannot.
He can't hear. That's why I wanted us to finish so that
we check. Hilal, check your connection because we can hear you clearly.
So if there's any question, please feel free to ask.
Oh, now he can.
Ultrasound now is becoming something that you need at point of care, so I'm sure at some point everybody will probably have an idea of how to use ultrasound. We know there are legal issues to do with who needs to scan and who doesn't. Can you hear Hilal? You can, thank you. So I was saying thank you very much for the presentation. It was quite good. I was just asking about, I know you have your Volvuson AVC, especially very good for fertility specialists. It's making work easy when it comes to antrofollicular count and tracking during IVF. My question is I've not followed your color coding so much. Is there a way you can tell between the difference between a cyst, apart from the size, and a good follicle, based on your color coding on the AVC, Volvuson AVC?
So IVC can detect any follicle, any cyst. But no, there's nothing that you can compare between a follicle and a cyst.
Okay, thank you.
Usually I increase the cross beam so that I can see the shape of the follicle. It's normal or it's not.
Yeah, the reason I'm asking, yes, the reason I'm asking is sometimes when we are doing the first scan on day 3, when we are starting IVF, you get some patients who have got probably a follicle that is more than even 1 centimeter thereabout. So you are confused whether is it a follicle, is it a cyst on day 2, day 3 of their cycle. So that's the reason. I wanted just to find out, is there a distinct at that point that you can now, with time, you can tell this was literally a cyst from the beginning. Thank you. So anybody else could ask? Dr. Moledina, thank you.
Hi, Dr. Hilal. It was a very good presentation. Assalamu alaikum. Okay. I wanted to ask you what Dr. Ogweno has just asked. Is it possible when we are trying to track and to find out whether the follicle has got an egg or it's just a follicle? You know, it's very important that this thing, because I just had a patient who really is desirous to have a child at the age of 52, and I'm trying, but finally we found out some of the follicles which we were thinking carries an egg and it does not have an egg. Can you try to clarify if there is any method by which we can do it?
Any other question? I will help you, Hilal, on that. I think we can discuss.
I can send you an email showing you the benefit of having a BBC Ultra.
Okay, Mike, thank you so much for the presentation. My question is there specific preparations for the patient who is going to use that machine for the ultrasound?
Can you please repeat?
They're asking if there are any special preparations. No.
No. It's just an ultrasound like
Yeah,
any
it's just
ultrasound.
an
Is only the, how do you put it? It's more detailed. But it's just an ultrasound. You can do
like
it
any other,
transabdominally. You can do it TVS.
Yeah.
Mostly for fertility patients. I'm sure TVS is one of the areas of preference, especially if you're doing fertility. But if Hilal wants to say something on that, please feel free. She's asking whether there's special preparation for the patient. Sorry.
No, it's only a visualization scanning. The ultrasound is visualized. There's no preparation.
Thank you. I think what my colleague Dr. Moledina also talked about, a 52-year-old looking for a baby. I think it's something, yes, it's something we need to, because I know I read an article the other day, the first baby of 3 parents, the first one in the world has been born in the UK. So the baby must have been born through what we call mitochondrial replacement technique, which now I think is coming up, especially it is used for diseases, but now it's also being used for fertility, I'm sure, for those who are at least in advanced age past 35. So mitochondrial replacement technique is something that is coming up, and I think it is the next thing in future. Thank you. So, any other question, please, before maybe we'll invite Judy to talk about basics of ultrasound, so that we can release Hilal. Any question from anybody? Anything? I think it is very clear. Any questions? We are good? Okay, thank you very much, Hilal, and I think a round of applause before we let you go. Asante sana, thank you, and we hope to see you tomorrow. Thank you. Okay. So now I think the next topic will be given by Judy Nyaboga. It's just basics of ultrasound, and as we all know, ultrasound is becoming something for point of care. So I think it will be important to know how to handle ultrasound, what we expect from ultrasound. So Judy Nyaboga, Daktari, she's been with Nairobi Hospital for also quite a while. Now she's representing GE, and they have been quite supportive in our symposium, and now I think we are going the CME ways. We are going to do a lot of CMEs. So I would like to invite Judy to talk about basics in ultrasound. I don't know if when you are ready. Okay. So Judy, the floor is yours.
Yes.
Yes.
Meanwhile, as they are sorting out, I just had a small presentation on basics of ultrasound, which I'll take you through. I know most of you might or are not familiar with some of the terms you hear ultrasound people using, how the probe is, what is the probe, the movements they make when they are scanning. So mine is just a basic, and if you have any questions, kindly ask. Stop me at any point and ask any question that you might not understand. So I don't know whether it's clear. Is it clear on the screen? So I'll take you through some of the terms that are used in ultrasound. I know if you've had in X-ray, we have what we call ALARA. We also have it in ultrasound as well. It stands for as low as reasonably achievable. Remember in first trimester, we look at the sound wave. It's also not very safe for the fetus when the fetus is still developing. So that's why we come up with the ALARA principle. So I'll also take you through the anatomical image planes, the sagittal, axial, coronal views that you hear the sonographers talk about. I'll take you through the few terminologies, how ultrasound images are created, the probe display and orientation, the probe movement, and the image optimization, and how to take care of the ultrasound equipment. So I'll go to the anatomical imaging planes. So you hear of sagittal. Sagittal is just a plane that separates the body, divides the body into right and left. As you can see on the image here, this is the sagittal plane. And axial, which most of the time you hear as transverse, is the plane that divides the body into superior and inferior. Coronal is the plane that divides the body into anterior and posterior. And this is in regards with the patient. So as you are learning ultrasound, it's important to understand the maternal and fetal scan planes. As you are scanning, the instructors will give you guidance on how to move the transducers to achieve the anatomical view the view of interest that you might want. So they will refer to the maternal and fetal scan planes. Most of the time you will hear of sagittal, axial, and coronal views. So in regards to the fetus, sagittal, a vertical plane that divides the body into right and left. As you can see on this image of the fetus, you can see that the coronal view, as you place your probe, it divides the body into right and left. And axial, which is transverse, it divides the body into superior and inferior. Then the coronal one, which divides the body into anterior and posterior. These are the most commonly used planes that you will hear the sonographers or the radiologists using most of the time. In addition, So in addition to the sagittal and axial planes, the coronal scan plane is also used when imaging the fetus, because you will most of the time see that you will be scanning posteriorly and anteriorly. So that's where the coronal views comes in, especially in obstetric. So we will go to the ultrasound terminologies that are mostly used in ultrasound. When you hear of anechoic, it is no echoes, a dark, like cyst-filled area. As you can see on the image, anything dark is anechoic. So we go to the heterogeneous. It refers to the mixed, either can be white and dark. It's just a mixture of any varying composition. The term heterogeneous is also often used to describe the appearance of tissue within an ultrasound image when there are significant differences in grayscale within a structure or organ. It is often described as heterogeneous. So as you can see on the image here above, you can find that some areas are more darker, whitish and darker, so that is heterogeneous. So we go to homogeneous. Homogeneous refers to a uniform or non-varying composition when the tissue speckle pattern and grayscale within a structure or organ appears uniform. That is when we call it homogeneous. As you can see up here, this is an image of a placenta. Especially in second trimester, you'll find that the placenta is smooth, so we call that homogeneous. Then as the fetus age, you'll find that it has a mixture of echoes, then we call that heterogeneous. In this image, the uterine wall, the fluid-filled maternal bladder, and the gestational sac could all be referred to as homogeneous, as they all are uniform in ecotexture as a whole. Conversely, the vagina appears heterogeneous as its muscular walls are a mid-level gray and its canal is bright. So you see when you have a mixture of gray-white, we call that heterogeneous. So most of the time you will find that you will get reports written, this is echogenicity. What do they mean by echogenicity? It's the amount of echoes that are produced. High echogenicity structures appear brighter. As you can see here, this is a bone. So a bone has more echoes, so it has higher echogenicity. Low echogenicity structures appear darker on ultrasound, just as you can see here on the wall of the uterus. This is lower and the bone is high echogenicity. So hyperechoic, still brighter ecotexture. As you can see here in comparison with the uterine wall, you see that this is hypo, darker, and this is hyper, a bit brighter. So isoechoic, it is the same ecotexture. When you have, I know you might ask, what is the difference between homogeneous? Homogeneous is uniform, but when we come to ecotexture, the brightness, then we say isoechoic, same ecotexture. So echogenicity refers to the amount of echoes that are produced. High echogenicity structures appear brighter, whereas low echogenicity structures appear darker on ultrasound. On the same ultrasound image, you see the higher echogenicity fetal femur appears brighter, just as I've explained. Then the femur is more echogenic than the surrounding tissues. The anterior placenta is a lower echogenicity structure when you compare it to the femur bone. So we go to how ultrasound images are created. How ultrasound images are created. Of course, you must have your ultrasound equipment, and then you must have what we call a probe. Then ultrasound system creates a sound wave that then it listens to the returning echo, and then it takes the returning echo goes through the probe, and then you have very strong echoes coming up. So we call that the strength and brightness. So stronger echoes, they appear more bright. And then the weaker echoes, they appear more darker. That's why we have a few buttons on the ultrasound systems that you are able to adjust those delayed gains on the ultrasound. So diagnostic ultrasound uses high-frequency sound waves to create images of structure within the body. Sound is transmitted into the body, and the returning echoes are listened by the transducer, also called the probe. The ultrasound system places gray dots on the display screen to represent the depth and the strength of the returning echo. The brightness of the dot is determined by the strength of the returning echo. The stronger the returning echo, the brighter it is displayed on the image. The weaker the returning echo, the darker it is displayed on the image on the ultrasound system. That's generally how ultrasound, how we actually produce ultrasound. Very simple. So you have your probe, then the sound, the returning echoes. So in some areas you'll find that the ultrasound images appears darker. So that is the returning echoes are weak. So you can actually adjust that by increasing brightness on the ultrasound image. So we go to the anatomy, that is how the probe movements are created, or rather how they are made. Anatomy that is closer to the face of the probe is displayed on the top of the display image. And anatomy that is farthest away from the face of the probe is displayed on the bottom. So it's very simple. As you see, when they are scanning, the probe has a marker which represents the right of the patient.
or the right of the fetus, but definitely because you're facing the patient, it will be your left. So as they are moving, any structure that is closer to the probe, it will be on top. And any structure that is away, it will be further down. So a bit of some of the probe movements that we might come across. So the long axis, we have long axis, short axis, and then the rotation. So the long axis of the probe is along the length of the probe face. These movements are described as towards or away from the orientation notch. The notch that is always showing you where the right is and where the left is. When we go for the hands-on session, I'll show you how to actually know where the notch is there. So always make sure when you're scanning, the notch is on the right. If you invert it, then your organs will be inverted. That's why it's very important even during your movements of the probe. So as we have seen, the long axis of the probe is along the length of the probe face. These movements are described as towards or away from the orientation notch. Moving along the long axis of the probe will display more anatomy on either the left side towards the orientation notch or right side away from the orientation notch of the display. Remember, the orientation notch on the probe correlates to the orientation icon on the image display, that the display where we see the images. So, and most of the time, every company denotes it with their company logo. Like for us, most of the time, you will find that our right is has the annotation of the G logo. In this ultrasound image taken with the positioned sagittal midline on the patient, we see the fetal head and the spine. The spine is towards the orientation notch, and the head is away from the orientation notch, as the above image is showing you. So notch will display more of the fetal spine, and the fetal head will get cut off, moving the probe along the long axis of the probe, away from the orientation notch. That's basically how the movements are. As you are moving away, then you will, with the orientation head, the other anatomy will be moved away. So we have the three simple movements. We have the long axis where you slide and angle, then the short axis, you slide or angle, and then to rotate. So to understand how to obtain the ultrasound anatomy of interest, you must first understand how to move the probe. There are only three simple probe movements that are used when scanning. Understanding these probe movements are critical to your success in ultrasound. The three movements are the long axis movements. This can either be sliding the probe along the axis or angling. You are moving along the axis but angling minimally. If you angle so much, then you turn the movement. So for the short axis, this can either be sliding the probe along the short axis. So you're sliding it like this. So you're sliding it on the short axis or angling along the short axis, but remembering not to rotate. So rotational movements, this can either be rotating the probe clockwise or rotating the probe counterclockwise to be able to get the anatomy of interest. So those are the three movements, and we will look at them closely here. When angling may also be called rocking. You hear them, maybe a doctor saying, kindly tilt towards the right. So tilting the probe, it's the same like angling. Angling along the probe's long axis is similar to moving along the long axis of the probe, except the probe stays in the same location by angling the probe towards or away from the orientation notch. More anatomy is visualized in that direction. For example, in this same image taken, more of the spine will be displayed conversely if the probe is angled away from the orientation notch, just above the above image. More of the fetal head will be visualized angling the probe along the long axis to be able to see the results of this, the head. Sliding the probe along its long axis movements and angling along the long axis aids in concentrating or centering the anatomy of interest. So whenever you want to center maybe the fetal head, abdominal circumference you want to take, you must angle. You will see, even if you're on the short axis, you'll be able to move a bit to be able to get the correct measurement. So those are the three main measurements and how to move to be able to get those. If you get those movements, then definitely you will be able to know how to do the scans. So this is the same movements. As we can see, the anatomy, fetus, all this. Moving along the probe short axis, you locate the anatomy. Maybe you are looking for the fetus head. You have to a bit of rotating and angling to be able to get the fetal head. That's basically what it says here. This is just the same movement. So in general, just a quick tip to remember, when you are doing short axis, you are locating the general anatomy. Long axis, you are centering the anatomy. And short axis, you locate specific anatomy. Then when you are rotating, you are elongating or shortening, displaying anatomy. You will hear more when they say you are for shortening. You will realize that when you rotate it completely, then you're for shortening. But when you try to angle a bit of it, then you will elongate your anatomy. We will see that when we go to the hands-on session. You'll just see how they are trying to angle to get, if it's the femur length, and how the movements they are able to make. But these are the three basic ultrasound movements that you have to make to acquire an ultrasound image. I think that's it from me, Daktari, unless we have questions. Do I go into the depth, the gain, how to increase?
Pardon?
Can I go slightly deeper
Yes.
on how to increase the depth?
Yes.
All right.
I was even going to ask, I see you've not discussed the TVS probe.
Oh, yeah.
I know that is one of the areas.
Exactly.
In fact, when I was beginning to do TVS, I thought I'm in a different world.
Oh, yeah.
In terms of how
when you're training them for basics,
yes.
you know, they will look more on the transabdominal scans.
That's what
Before you go to the TVS, you must at least know the anatomy of the transabdominal. Then the TVS will become easier. But when we go down, for sure the TVS probe has also a right and a left. Yes. So it's only that its right is normally the notch is up. So know that when you're going in, the up marker is your longitudinal. And when you just turn it, then that is short axis, which is transverse. So the long axis and short axis, those are the two that you will mostly maneuver during TVS. And we will see that in case we get to have a chance to have a patient with TVS. Yeah.
Okay, just continue.
Yeah, so we have a few things that will help you, especially in ultrasound, and this one you cannot avoid them, even if you're learning basic ultrasound. When you just start scanning and you find your image is far off, you're wondering what to do, is my machine okay? So there are a few maneuvers that you'll be able to do. For example, depth. If your image is too deep, you need to increase your depth. If it's too shallow, then you have to reduce your depth. So there is you don't need to worry about that. All the ultrasound equipment have the depth button, all of them, whether black and white or color Doppler ultrasound images. So this is the first, when you're just starting to scan, you will see that, maybe your image is zoomed. What do I do? It is too shallow or too deep. What do I do? There on most of the equipments, it's written, but most of some of the equipments they indicate it with an arrow, just indicating that this is the depth button. So those are the maneuvers you'll be able to do. If it's too deep, then you need to increase your depth. If it's too shallow, then you reduce for you to be able to get your anatomy up. Just as you can see here on the three images, too deep, it is down, so you're not really seeing it clearly. You might be tempted to zoom, but again, zoom might reduce your quality, it will drop your frame rate. So we most of the time would just want to increase the depth button. So locate the depth control on your system, increase the depth to see deeper structure, and decrease the depth to focus on more shallow structures. The depth should be adjusted as the anatomy is visualized without cutting off any diagnostic information. Having the depth set too deep will reduce the image resolution and also slow down the processing speeds, frame rates. These images are of a first trimester fetus. The image on the left has the depth set too deep. Notice how the resolution detail on the fetus is reduced. The image on the right has the depth set too shallow. Notice how the back of the fetus is slightly cut off. The image in the middle has the depth set good and all the fetus anatomy is displayed good. So you have to really check all this. That is the first thing you do when you go to your machine, you've taken your probe, you're scanning and you realize you're not able to visualize your anatomy clearly. Just check, is it the depth that is too high, too shallow, or how do you want to adjust it? Then you adjust it accordingly. Even if you don't know how to adjust the depth, just rotate and see, is it taking me up or down? Then you can be able to adjust in the middle and your resolution will be also adjusted accordingly. So for gain, when you first start scanning and you find that your image is too dark, the echoes are too dark. We saw like when the echoes are sometimes delayed, they might be too dark. So what will you do? You need to, there's also a button on the ultrasound equipment that you need to adjust your brightness. It's for, we call it 2D. It's for the overall gain of the image. It brightens your, it makes your image brighter or darker according to how you want it to be. If it's too dark, definitely you want it slightly brighter. So that's what we can see from here. So too low, meaning slightly darker. Then good brightness, this is in the middle. Then also too high, it makes your image more like white, bright. So another very important button that you will also see on the equipment is the freeze button. Anytime you want to acquire your image, you want to freeze you want to measure your images, there is a button called freeze. Most of the images, most of the machine might not indicate freeze, but every equipment has to have the freeze button. It's also used to store the images in video form. So this is also a very important button to have in your ultrasound equipment so that you're able to capture your image, do your measurements, move the way you want to adjust, do your measurements accordingly. So once the anatomy of interest is located and the image is optimized, using gain and depth, freeze the image to store and or take measurements to freeze the image. Locate the freeze control on the system. Once the image is frozen, select the store option on the system to save the image. If you need to scroll back a few frames to get a previous image frame due to patient or fetal movement, use the cine feature on the system. This image is of a fetal head, the above image. So yes, this freeze button is quite important for freezing, for storing. You can be able to store your image after you've frozen and be able to also play back in video form. this way. It's either this way or this way. Yeah, just the two. Yeah.
Yeah, thank you. Thank you. And I think practice makes perfect, so
Yeah.
hands-on
Yeah.
hands-on will be quite good.
Yeah.
The ones who need to make it in the morning, I don't know if the afternoon we have any.
Oh, yeah. In the afternoon,
Any-
do we have any scanning?
No, we don't. But practice makes perfect. Yeah, any concern, any questions? It's well understood. Judy here.
Yeah.
Hi, Judy.
Oh, Judy, namesake.
Good afternoon, and thank you very much, Judy, for the presentation, and especially for some of us who are not really
Yeah,
hands-on
trained.
on ultrasound, but it's very enlightening,
Yeah.
especially when we get those reports. It helps us to interpret. Slightly away from your presentation, but I'm looking at where we are going to. This is point of care ultrasound.
Yeah.
And knowing that ultrasounds are usually user dependent, if I'm correct.
Yeah.
So how do we protect against misdiagnosis or missed diagnosis, especially with the point of care or even in central care?
Sure. So even before can you be able to slightly project this? I want to show you something that we've come up with, and we are partnering with the institutions to train the midwives, and specifically on point of care. So we've come up with an very handheld equipment that will be specifically meant for the midwives. It's a pocket ultrasound equipment that we will be training OBGYNs and midwives and physicians on just basics of ultrasound. And we will be going around, once we launch it, we will be going around hospitals just to partner also with institutions like KMTC to train midwives on ultrasound. It's not for diagnostic purposes. That's why if you want to do it more diagnostic, then we go for the bigger equipment. So ours will be tailored to help you make that quick diagnosis. Like if you really want to know the presentation, must you send the patient to radiology really? No. So look at this equipment that we've, there's no sound. There's no sound. Is it on my side? Yeah? Start. I just want to show you how actually how now diagnostic will be. Okay, just as you've seen that it's actually a handheld equipment that we've made specifically for physicians, midwives, and it can scan actually whole body. So as you have seen on the top, it has a convex and a linear probe. So what we are going to do with the probe is, all we are looking at is helping the midwives, the nurses, any healthcare personnel, apart from maybe the sonographers and radiologists, to be able to make that quick diagnosis. Maybe a patient has come and it's an RTA. You're really looking at, is the patient bleeding internally? Then this is an equipment that you just place and quickly make a decision whether to rush the patient in. You want to check for presentation. So those are some of the structures that we've made for the course that we will be running for point of care. So we will limit it.
Really get what Judy is asking also. I know it's something that it is eliciting a lot of discussions when it comes to medical legal issues in terms of ultrasound. I remember at some point we were wondering, us as fertility specialists, we start doing most of our ultrasound, but the question is, should it be done by radiologists or should it be an area that we should take up fully? So I think when it comes to some misdiagnosis or something like that, that's what Judy is talking about. But I think ultrasound is just like mobile phone. I don't know how we can restrict mobile phones, so I don't know what age we'll say you cannot have a mobile phone or you cannot access this technology. So it's something that is revolutionizing, and we see how we can take care of all those areas that might bring a lot of mitigations and all that. Yeah, because you can't stop. You can't say now that, I know the other time we are discussing only, I don't know how, Judy, you think, should ultrasound be done only by radiologists? I don't know. I mean, your personal thinking.
You know, ultrasound is evolving for sure. And now we've seen that since it's actually the most preferred, remember the other diagnostic tools are more of radiation oriented. Yes. But now ultrasound, even in those other countries, for sure, ultrasound should be moved from just being done by radiology, sonographers alone, to just it will save lives, for sure. If we bring it down to other cadres, it will really save lives.
Thank you.
Yeah.
Thank you. I totally agree. Any other action, Moledina?
Judy, how much would this cost, the hand one?
The handheld one, I'll give you the maximum price for now, but definitely it will not go beyond that, 800K. 800? Yes.
800,000?
Yes, it's a linear and convex probe. Imagine buying the two probes, they will go for approximately 2 million, but now we are selling to you at 800, below $1 million, then it's fair.
For private clinics, would you give some discounts? Or
yes, when we launch, kindly be one of them. When we launch, the price will significantly go down.
And for senior doctors, senior citizen doctors?
You
Yeah, that's a good one.
And remember, it's compatible with Android and iOS. It's wireless. So you just get the app on your phone, on your tablet, on your whichever phone, and you're able to scan. You only buy from us the probe, and it's 3 years renewable. Meaning after the 3 years have elapsed, we give you a new probe. Yeah.
So in fact, Judy, I'm seeing that portable ultrasound is just like when you have your ultrasound in the office, it's like you have a landline.
Exactly.
And now the portable will be the mobile, which everybody goes with over time. So that's where it is. You might, some might disagree, but I think that's the future.
Sure.
Yeah, that's the future. Thank you very much. Any questions? Any more questions? You've been quite quiet on this end. Everything understood? Sawa, sawa. Thank you very much. Thank you, everybody, for making time to come. I'm sure it's past 3:30. If there are no questions, probably I would like to thank you very much for those people who came in the morning. and who are there for the scanning. We'll be doing this often, so I'm sure hands-on will be there. At the moment, ultrasound looks funny, but once you hold the probe, you get used to it. It's much easier to manipulate. So thank you, Judy, again. Thanks, GE, for facilitating this. We really appreciate. And we hope tomorrow is another day. We look forward to seeing most of you at the... We'll be having our symposium. We could still go back, eh?
Yeah, sure.
Yeah, but if there isn't, then I will just... I don't know if they have served tea, eh? There was a lunch, a late lunch, so tea, I'm not sure. All right? There is tea, eh? Let me not... It's Moledina who has said, don't... so if it's not there, don't take me to task.